Good afternoon, everyone, and thank you so much for joining in today. I'm Dr. Kim Newell Green, and I'll be the moderator for today's virtual Grand Rounds, which is entitled Strategies for Turning a Corner on COVID-19, Vaccine Rollout, Various Virus Variants, and Vaccine Hesitancy. Next slide, please. Before we begin, here are the disclosures for our speakers today. Next slide, please. And just a reminder that CME, this is our agenda. Next slide, please. Just a reminder that CME is being provided for the speaker series. You will be sent a survey after the completion of the webinar where you can attest to your attendance. Make sure you complete that survey so that we can send out your certificates. You can see here our objectives for the webinar today. Next slide, please. And so as I sit here, in my office in San Francisco, it is spring in the Bay Area. The magnolias and other spring flowering trees have just burst open in the past week. There's a big bright patch of daffodils in the front of my house, and it really happened in the blink of an eye. As we enter February, and I know at least one of our attendees today is on the East Coast, and it's very cold there, but as we enter February and spring here, the COVID-19 trends have also turned in what feels like a blink of an eye. Though the numbers of cases are still higher than they were in the peak in July, the shape of the curve, which we'll see today, is looking very good to me. And we have great hope and excitement on the vaccine front as well, with several new vaccines looking like they'll be available in the next couple of months, one as early as March potentially, and an increasing pace of vaccine delivery in our state and our nation. We have much to celebrate. The years since our lives were disrupted by a global pandemic has seemed so long, and yet in relatively short periods of time, we have accomplished so much. I just wonder at the science and industry of it. In many ways, I think we should actually be having national celebrations with fireworks at least. And yet we're seeing a lot of doom and gloom and a lot of criticism and negativity in the media and other places. And while I certainly don't think we should ignore the uncertainties of this time, the new variants, the difficulties of the vaccine rollout, and the personal and economic toll of this virus, I hope that the emphasis of our national conversation can also focus on the great accomplishments and on hope, and that we begin to see some celebration of our small, medium, and large milestones. Rather than waiting to exhale, I hope that we can all take a moment to breathe fully in and out and smell the flowers. Today, I am breathing fully and with excitement as we have several wonderful speakers and leaders to share details and hope about the vaccine rollout from the national and the state front. Dr. Bashara Shukair, who recently moved from California to work in the White House, yes, the real White House in DC. Dr. Erica Pond from the California Department of Health in Sacramento, yes, Sacramento. Erica is our frequent guest on our series. We'll also hear from two speakers who will talk to us about a vital issue as we move forwards to a time, hopefully, of plenty in the vaccine world. Doctors Ken Hempstead and Henry Ton will give us some concrete strategies to help address our colleagues, patients, neighbors, and communities who are uncertain about the COVID vaccine. We will address your questions following these conversations as time allows, so please do submit any questions you may have throughout the presentation by using the question box in the control panel located on the right-hand side of your screen. Now I'd like to turn the time over to Dr. Bashara Shukair, the vaccinations coordinator on the White House COVID response team. As the White House COVID-19 vaccinations coordinator, Dr. Shukair is responsible for overseeing the national vaccination efforts under the Biden-Harris administration, focuses on coordinating the timely, safe, and equitable delivery of vaccines for the US population. Prior to joining the administration, Dr. Shukair served as Senior Vice President and the Chief Health Officer at Kaiser Permanente, where he oversaw the organization's efforts focusing on addressing the social health of its 12.2 million members and the 68 million people who live in communities it serves. He has a long list of other accomplishments, which I won't read so that we can actually hear from him, but suffice it to say, we're very grateful for his service to the vaccine effort now and for taking the time to speak with us today. Dr. Shukair.
Great, thank you so much, Kim, and thank you for inviting me to join this group and be part of this Grand Rounds. It's great to be in DC. I spent the last 4 years in California at Kaiser Permanente, and I got a chance to interface with many of you, and CMA was a big partner to us, particularly in the last few months where I served as the co-chair of Governor Newsom Testing Task Force. So I'm really excited being part of the Biden-Harris administration, focusing on vaccination efforts and getting us into hopefully getting people vaccinated so we can get past this pandemic. So I have brief remarks, and then I look forward to question and answers. And I'll start by reminding everyone that a couple of weeks before inauguration, President-elect Biden at the time launched our national vaccination strategy. And that strategy, it really boils down to three things. We want to make sure we have more supply of the vaccine. We want to make sure we have more places where people can get vaccinated. And three, we wanted to get more people vaccinated. And the president has set an ambitious goal of getting 100 million shots in the first 100 days in office. And we've been working really hard to be able to meet that goal and exceed it. So what I thought I'll do in the next few minutes is I'll give you updates on where we are on supply, where we are on creating more places for people to get vaccinated. And then I'll share with you towards the end a little bit of highlights on where we are when it comes to numbers of people who are vaccinated, some of the data that we're making available. So we'll spend a few minutes on that towards the end of the presentation. So let me start with supply. I think supply of the vaccine has been front and center on everybody's mind. And I have to tell you, in my first 18, 19 days on the job, everybody I talk to, they ask about supply. We want more and more vaccine. So I'm happy to report that over the last 3 weeks, we continue to increase supply that's available to states, tribes, and territories across the country. Just earlier today at 11 o'clock on a call with the governors, we've announced that now we're increasing our weekly supply to 11 million doses per week. And that's an important increase when you consider that when we started 3 weeks ago, we were at 8.6 million doses. So from 8.6 million to 11 million doses, that's about 27% increase in making sure that we have more vaccines that's available to states, tribes, and territories, and hopefully more vaccine getting into people's arms. We also now are ensuring that every one of the Pfizer kits includes all the supply that you need to be able to extract that 6th dose. I know many people across the country were actually able to extract the 6th dose, and now we're making sure that everyone would be able to extract that 6th dose by ensuring the appropriate supplies in those Pfizer kits. So that's on the supply front. We also heard very clearly from states and local health departments across the country that it's really important for them to get predictability or visibility to what's coming down the pike, so that they can plan better. And I can't agree with them more. It's really hard to plan if you don't know what to expect in the next few weeks. And I keep reminding myself and others, I served as a health commissioner in Chicago for 5 years. And if you tell me, go ahead and stand these community vaccination center, but then we're not gonna tell you how many vaccines you're gonna get until 2 or 3 days earlier, it's just really, really hard to plan. So that predictability, working on predictability to states and local has been a key part of our strategy, and we're making commitment to states and local that this is what to expect in the next 3 weeks. So we have visibility for 3 weeks for our partners at a state, tribes, and territorial levels. So that's on the supply. We're really excited about the progress we're making there. We're not there yet. We still have a long road to come, but we know that those incremental increases are really critical to making sure that more people will be able to get vaccinated. The other piece that the president announced, I think now a couple of weeks ago, is the commitment to purchase 200 million more doses, 100 million more of the Moderna vaccine and 100 million more of the Pfizer vaccine, to get us to a total purchased for the United States of 600 million doses. So that's enough to vaccinate everyone in this country. So we're really excited about the incoming supply, and we'll hope to be able to get those by the end of the summer. So the additional 200 million doses. So a lot of work on the supply piece. The next part of the remarks is really about creating more places for people to be able to get vaccinated. And I think this is really important because at the end of the day, vaccines is as good as it is when it gets into people's arms. So at the president's direction, FEMA has increased its support to states, tribes, and territories for vaccination sites. And we've been FEMA has been working with states, tribes, territories on adding more community vaccination sites across the country. And FEMA is offering all types of support, anywhere from providing financial support to run these sites, all the way to be able to have turnkey solutions that would be able to come in at the invitation of the states and jurisdictions and be able to stand and run these community vaccination centers, and everything in the middle, from staffing support to logistics support or others. And we're really excited how this program has been up and going. There's already lots of resources that have been dedicated to this program. FEMA's working hand in hand with states and tribes and territories across the country. There are over 1,000 staff that's now supporting vaccination sites across the country, from the FEMA side, from the CDC, even DOD, and there's over 1,000 staff from the National Guard. And keep in mind that this type of community vaccination center, there is no one size fits all. So FEMA has been working with jurisdictions to figure out what is the type of support that those states would need to stand these community vaccination centers. So we're really happy about this program. We're going to continue to see more and more of those. The president made a commitment to have 100 of these community vaccination centers by the end of the first month. So we're working really hard to beat that goal as well. The second example of creating more places where people can get vaccinated is our federal pharmacy program. And this is about really beginning to build the infrastructure for additional vaccination channels. Last week, we've launched a limited phased approach with pharmacies to make sure that we have that channel ready when supply becomes more readily available. So I wanted to be very, very clear on this program. We are starting this program in a limited phased approach while vaccine supply remains limited. So this is how this program will look like. So starting on February 11th, the federal government will deliver directly to select pharmacies across the country additional vaccine that's coming online this coming week. And this is above and beyond the allocations that states receive on a weekly basis. The additional allocations will provide more sites for people to get vaccinated in their communities, and is an important tool or an important component of delivering vaccines equitably. And I just want to finish the remarks about this pharmacy program by setting expectations appropriately. Due to supply constraints, this program will be limited when it begins this week. And many pharmacies across the country will not have vaccine or may have limited supply. The initial phase of this program is to activate local pharmacies so we can get more shots into people's arms, but also more critically important is to ensure that pharmacies have the infrastructure, have the experience they need to scale up when vaccine supply increases in the months ahead. Eventually, we will hope to be able to increase the number of pharmacies that are part of this program up to 40,000 pharmacy locations nationwide that will be able to provide vaccines throughout the country. And these would be places ranging anywhere from local independent pharmacies all the way to national pharmacies across the country. So I'm really happy about this, and I know that this will be a promising channel for us to be able to get a lot more people vaccinated. The third program, where we actually just launched a couple of hours ago, is our work with federally qualified community health centers. We've just announced this earlier today, and this is part of our broader equity efforts that's focused on the underserved and hardest hit populations. This effort also includes community vaccination centers located in hardest hit areas. It includes mobile units. It includes building vaccine confidence. But starting next week, we will begin shipping doses directly to federally qualified health centers, or as many people know them, community health centers, on top of jurisdictional allocations. So this will be above and beyond what states get when it comes to vaccine. Now, I know that many of you know the important role community health centers play across the country. Many of you are very familiar with them. Many of you practice in community health centers. Just to give you a perspective nationally, community health centers serve about 30 million people across the country, 2/3 of whom are living at or below the federal poverty line, and 60% of whom are racial or ethnic minorities. And let me just also reiterate that this program will take a phased approach and will ramp up as more vaccine supply becomes available. So a small set of community health centers will start ordering vaccines next week. And over the next few weeks, we will allocate about 1 million doses across the country for this initial phase. This program will also be inclusive of all states. So in the first few weeks of this program, we will include at least one community health center in each state. And as the program further scales, vaccine will become available to all 1,385 federally qualified community health centers across the country who are actually interested in wanting to be part of this program. And one other point I want to make, and this is about local efforts. And in order for us to vaccinate everyone, it's going to take leadership at the federal level, state level, local level, the private sector, the public sector. It's going to include faith-based organizations. And we want to make sure that we're all working together to making sure that our vaccine distribution is done equitable. Equity has to be at the center of our response, and I'm hoping it is at the center of your response as well. On the ground, we know that you are doing the work day in and day out, and introducing programs like the Federally Qualified Health Center is really about supporting you and your efforts and making sure that we are providing support and outreach to hardest hit communities or communities that might not be ready to actually come in and stand in line in community vaccination centers or in other places. So that's on more places to create more vaccination. I want to spend just maybe a couple of minutes before we'll open it up for Q&A here to just talk about some of the data that we've been reporting, and I would encourage you to check out our CDC COVID tracker. If you haven't seen it, I would definitely encourage you to do so. And maybe actually we'll move to the second slide. I have just a quick rundown of slides. These are some of the key metrics that we're tracking. What's happening with the total number of cases. This is what you see across the country. The good news is we've seen for the first time in a long time number of new cases less than 100,000. Week-on-week change has been about 20% decrease. We track hospitalization, we're tracking deaths, we're tracking number of tests at a national level, positivity tests, and we're tracking the vaccine doses administered, and I'll spend a little bit more time on that. So as of this morning, I think I just did screenshots of those dashboards. We're at 42.4 million vaccine doses administered. Our 7-day daily average, we're now at 1.4 million, a little bit more than that. So we're really encouraged to see the increases. It's 7.5% week-on-week increase. The next slide, you'll see some of the metrics that we're tracking on cases and deaths over time. I'm sure many of you are tracking that. I know California does a great job on their CDPH website. The next slide shows how we're tracking our goal to get doses. So we track that on a daily basis, and we're on day 19 and we're at 25.8 million doses. So we're encouraged by this, and we know that we have a lot more work to do. The next slide shows some of the data that you'll also see on the COVID tracker websites for the CDC. It talks about how many doses have been delivered to states. It talks about how many vaccinations have been made at states in the last day, the 7-day daily average, week-on-week change. So this is an important part of what we track on a daily basis. The next slide, you'll also start seeing that actually as of 11 o'clock today, on the CDC website, we're tracking the total daily count of total doses administered and reported to the CDC. So we keep an eye on that. You'll see usually the last couple of days there's a little bit of lag, and once all the data is entered, those numbers will go up. There are 2 more slides I want to share, and not to go deep into the data, but I just want to highlight that the next slide, which is something that we've just started posting online, and again with taking that really important focus on equity at the core of what we do. Starting yesterday, now we're posting race and ethnicity data on the COVID tracker page at the CDC, so I encourage you to check that out. We'd want to make sure that we're monitoring this. We'd want to make sure that we're closing gaps when we see them. We're also tracking that by age group, and we're making it available. And then the last slide, as we just actually started publishing that, we just did this, I think at 11 o'clock Eastern today. And we know that states receive allocations for first doses and allocations for second doses. And now we're able to track the percent of delivered first doses administered. And I think this is really important as states are picking up the steam and being able to have more capacity to administer doses. We'd want to make sure that we're tracking that by first and second doses. So if you see here, you'll see Oregon, for example. I was just telling Kim I should have chosen California, but Oregon, for example, more than 90% of the first doses that are delivered are already administered. And that's an important metric that we're tracking to make sure that we're moving vaccines very quickly through our inventory, getting vaccines into people's arms as fast as we can. And now that we're seeing this map, we're being able to tell where each one of the states are when it comes to the percent of delivered first doses that are administered, becomes a critical tool in our toolbox to help us manage this vaccination effort more effectively. So with that, I think we can remove the slides, or we can turn to the next slide. And Kim, I'm happy to take some questions.
Thank you so much. Such informative stuff. And, speaking of waiting to exhale, I'm exhaling. It's really exciting to see the work that you are all doing as a team. Let me just ask you, since we are highlighting the issue of building vaccine confidence. I like that take on it. We called it vaccine hesitancy today, but what's your team's plan and approach? Can you give us any details about how you might do that?
Yeah, so we know that right now there is a lot of demand for the vaccine, and we're really excited about that, and we're working really, really hard to get people vaccinated. We know at some point we're going to get to a point where we have a lot more supply, a lot more places where people get vaccinated, and all this demand has been already met. And then we're going to get to a point where we really need to engage those who are vaccine curious, those who don't have the level of vaccine confidence that they need to actually get vaccinated. So we're working on a comprehensive public education campaign that we will be launching very soon in partnership with states and local jurisdictions to really help build that confidence. And Kim, I have to tell you, and for this audience, this is a no-brainer. It's really important that conversation that individuals are going to have with their doctors, with their nurses, with their social workers, because it's going to take a moment before people get comfortable, particularly those percentage of folks who are not ready yet for their vaccine. That one-on-one conversation with your provider is so critical. And that's where I see a big, big role for health systems, primary care docs, federal qualified health centers, and others, and getting that group to be vaccinated. The good news is we're seeing that the vaccine readiness is actually going higher and higher. So we're seeing surveys on a regular basis. So I'm encouraged about that. But I also know that we still have a lot of work to do there. And I'm hoping you all will be part of that journey to getting people vaccinated.
Absolutely. And hopefully we'll give people some good pearls regarding that today. As I looked at that curve of the progress towards 100 million, I've been curious about how you anticipate the vaccine supply to increase. Are we sort of going to steadily increase, or is it going to be sort of steadily increase and then a big uptick? And if that might happen, when? Do you have any crystal ball info about that?
Yeah, so the predictability of supply has been one of the most important question I get constantly, and we're working really hard to see how confident are we about the supply and how can we share that publicly and be open and transparent about it. What I can tell you at this point for the last 3 weeks, where we are today, is we're confident of the supply for the next 3 weeks, and that's what we're sharing with states and jurisdictions. We also know that we're purchasing a total of 600 million doses of the vaccine, and that we'll get those somewhere before the end of the summer. So we know there's a lot of work still to do, and as soon as we're getting more and more confidence in the supply, we're sharing that publicly, because we know people need to be able to plan, whether you're a provider who's delivering vaccine in your primary care setting, or you're a big health department that's running multiple community vaccination sites. Predictability is really, really important. So as soon as we get that, we're making that available.
Great. I think that one thing we're all awaiting is recommendations from public health about what kind of social contact those who have had the vaccine can and should have. How does their life change? Can it change? Are there any formal kind of national level CDC recommendations coming? Can we anticipate those?
I will bring this back to Rochelle, our new CDC director. I thought there might have been some that are out there already, but if there hasn't been, I'll check in with Rochelle. I thought there is one. And again, our key message right now is we really need to be doubling down on our common sense precautions to stop the growth of to stop this pandemic. And it's really about social distancing, it's about masking, it's about avoiding gatherings, and we really need to continue to double down on those messages. And I know all the audience here is reinforcing those messages with their patients.
Yeah, thank you. And finally, I know you have to run, and we're grateful for your time today, but I was actually quite serious when I started out talking about a plan to how important it is to begin celebrating some of our successes. And I wonder if your team's talking about a plan to celebrate milestones. I mean, I noticed that it looks like we may be at the place where more people have gotten the vaccination than have actually gotten COVID-19 infection. And we might be approaching having vaccinated, maybe we're above 10% of our population. So have you talked about the potential for really just saying we're doing a great job here?
Yeah, it's a.
And we have our fireworks. Sorry to interrupt.
Yeah, well, I have to tell you, we're right now focused on making sure that we meet the goal that the president set for us. It's an ambitious goal. We're working really, really, really hard to get to those 100 million shots in the first 100 days. But when people ask me, what's going to happen on day 101? Well, guess what? We're going to wake up. We're going to work equally as hard, if not harder, because we still have 400 more million shots to give. So we are very focused on achieving those goals. We're very focused on being here for states and local health departments, for our healthcare systems, for our people in this country. And we're going to do everything we can until we get everybody vaccinated and get us past this pandemic. So thank you so much for having me here.
Great. Well, I'll hope for fireworks along the way, and we're so grateful. I'll send them up just in the honor of all the amazing people doing this work. So thank you so much for being here.
Great. Thank you so much, Dr. Newell Green.
So next up, I'm going to introduce Dr. Ken Hempstead. Dr. Hempstead is a general pediatrician with Kaiser Permanente in the Sacramento area. In addition to his clinical duties seeing patients, Ken spends a significant amount of his time as a communication consultant to other Kaiser Permanente physicians, and he's the vaccine communication lead for Kaiser Permanente in Northern California. As such, he performs training and coaching around vaccine communication in California and nationally. And he's here today to talk to us about some tips that we've learned in the world of pediatrics, where there's quite a bit of vaccine hesitancy and curiosity, as Dr. Shuker would say. So welcome, Dr. Hempstead, and thank you for being here.
Wonderful. Well, thank you for having me. And yeah, we got our first slide up. So yeah, what an incredible opportunity. Obviously, yes, we're in a time where we're so eagerly anticipating vaccines to be delivered and administered. And we can really already anticipate, though, that that work is going to just be so successful that sooner than we can imagine, we're going to be really trying to tackle the hesitancy issue. And I think we have a very, very important amount of work that we can be doing right now in anticipation of that to see what we can do to kind of smooth that pathway. As was mentioned, I mean, it does seem that the public sentiment does seem to be, slowly turning more positive, and I think that makes sense as we get more people vaccinated. It's just, makes common sense to everybody that as we start to see our friends and neighbors be vaccinated and hear their stories, that we will naturally improve that. On the other hand, if some of these surveys are to be relied upon in the future, that's still going to be a big chunk of our population that we really need to do some serious work for in terms of addressing this timeline and getting everyone protected. So today is, a quick rundown of some ways to start framing these conversations and thinking about these conversations, because the time is now as the public is forming their opinions and watching closely for some messaging for us. So let's dive right on in. We can go to the next slide, please. All right, so of course I'm preaching to the choir, so I won't get into any detail here. I just like to always start with the why. So whenever you are personally, having these conversations, regardless of the level you're having them at, we always start with the why, and we try to come back to it pretty frequently. So, if we need to just gently remind folks of the impact that this has had on a number of levels on us as a society and personally. And speaking of personal, I really would recommend having if you have some personal stories or some experience with someone that has had serious COVID, that type of a thing, that really is what speaks to people. So that really is a very, very powerful way to remind people of the why before you sometimes get dragged down in the weeds of side effects, et cetera, et cetera. So if I'm imagining myself presenting this to my team at work, we always start with the why about what we're doing here, and that yes, the positive is that we can do something about it. Next slide, please. So specifically thinking about this first tier and looking at healthcare workers, we do have some work to do there. I think that everyone on the call is familiar with that. So certainly we've had some encouraging experience at Kaiser Permanente, where our physicians have been incredibly good about making the time to come in and get vaccinated and share that experience in a number of different ways. With our staff, it's been more difficult, and so that again is a bit of a harbinger about what is to come. So if it's difficult enough to convince our staff that it's safe to vaccinate, you can imagine the hurdles we might have outside of that community. So what can we do right now during this tier to try to improve that? So again, going back to kind of the why, so really framing this in terms of this is a privilege, this is an opportunity, right? So of course we're protecting ourselves, our friends, our family, and our patients. I mean, this is really part of the social contract. Society has deemed us a priority to be protected, and I think that we want to take that graciously and recognize that yes, part of that social contract is that we do take this vaccine and we protect them as well as ourselves. So understanding this is a privilege rather than a burden, I think, is a very positive frame. Next slide. So part again of thinking about this in terms of a privilege is not just getting the vaccine ourselves, but also what is our role in then sharing that story, right? So, it really is not just a matter of that direct, physiologic protection. It's really, hey, then we can become the people that are the storytellers to the rest of society to say, yep, I got my vaccine and I'm doing great. So yes, within our healthcare community and certainly beyond, we're going to need those reassurances. And again, personal stories, I can't emphasize it enough. Folks, we've really learned that simply relying on, we love the CDC and we love our other standard bearers in terms of delivering information. They're of course critically important. And we know that a lot of folks don't necessarily base their decision on, well, the CDC says this or the guidelines say that, in my venue, well, Kaiser thinks this. It's really the personal story. So nothing will ever beat your experience of, yes, I got my shot, I put my money where my mouth is, and yes, I did great. I'm glad that I did it. And absolutely, when it's time for my kids or loved ones to get theirs, I plan without hesitation to be the front of the line. Next slide. So starting to expand that idea beyond healthcare workers, there's kind of the similar idea of this is a privilege. And so some ways that we can kind of think about framing that is that as we move down the tiers, again, folks have been privileged ahead of others to receive this vaccine and to understand that and to hopefully accept it graciously. And so there's some different kind of ways that we can specifically remind them of that. So one of the ways that I like is again, it's a gentle approach, but gently remind folks that, well, there's other people that are really anxious to take your place in line. And that's a really great visual image, right? I mean, everyone can imagine, no one likes being cut, in front of in line or losing their place in line. And that just kind of hits home for folks. So yes, having that visual imagery of, hey, if you're not going to have your shot, someone else is going to take it for you. And we do know, looking at things like flu vaccine in the past, that yes, that's just human nature, that scarcity does indeed drive demand, and not wanting to be left behind is a very powerful motivator. And then, furthermore, we can gently just remind people that, well, the reason that you are a priority above others is that, yes, it's been deemed that you are at greater risk of COVID. So we're not trying to beat people up. We're not trying to induce fear. Fear is a very powerful motivator, but we've learned time and time again that inducing fear oftentimes backfires in the vaccine realm. So if you get people afraid, they're most likely to not end up being afraid of the disease. They will likely glom on that fear to the vaccine itself. So we're not a high pressure sales pitch. We're not trying to induce fear. We're just gently reminding folks of why they are ahead of others. Next slide. So, what do we know and how do we kind of message that? Again, I'm preaching to the choir, but how do we kind of packet this information to something digestible for the public and for our healthcare workers? So obviously Pfizer and Moderna have their authorization from the FDA. What I think is important to just kind of quickly be able to give a soundbite on to our patients or anyone who's listening is, of course, these phase 3 trials had the same number of patients as we would see in other vaccines that are also safe and effective that we use. So about 44,000 for Pfizer and about 30,000 for Moderna. So the elephant in the room is typically that the public becomes convinced that clearly this was a rushed process and we don't really know whether these are safe yet or not. And really that's just not the case. We really had good, robust trials as we would for any other vaccine, and frankly had far more volunteers for these trials than was needed, and they've really lucked out. I mean, they have gotten protection ahead of the rest of society, and ultimately we just need to deliver the message that yes, this was done quickly, which again I agree, we should be celebrating. This is the moonshot. We should be singing from the rooftops what a triumph of the system and of science this has been, and that does not mean cutting corners. Next slide. So, when people ask questions, we need to have some easy to digest answers. And okay, how then? How did they do it so quickly? So, the way that I tend to frame it is when we look at other vaccine development and why it takes so many years, frankly, a lot of that is just an economic reality for these companies. That, if every company invested hundreds of millions of dollars into every product that they were researching, they'd probably very quickly go out of business. And so, there's a very, very different business model with COVID, where, of course, with Operation Warp Speed, et cetera, we had such an enormous amount of dollars and pre-purchase of vaccines, so that these companies can move ahead with confidence, knowing that there is a pot of gold at the end of their rainbow, that they are going to get paid off for their efforts. And then again, with between the increased financial resources that were placed into this, plus of course the huge volunteer demand, you're able to accomplish the same trials that other vaccines or medications would go through, and do it in record time. So these are the same trials as the messaging we want to deliver. Next slide, please. So, again, I always love visual imagery. It's just kind of simple, but I tend to think of these home makeover shows. So just briefly, just one way of just thinking of, have you had an experience where if you put enough time and resources and people on a job, you can do things that you didn't expect could happen? And I think that's, when you see these homes being built in a week, it's like, wow, that's amazing. Took a lot of coordination and a lot of resources, but it absolutely can be done and have a wonderful high quality product. Next slide, please. All right, so what else do we know? So yes, we want to very clearly message that this is a very, very effective vaccine. So about 95% effective against contracting COVID. So we know that it works. We know that it's a fairly reactogenic vaccine. And so we want to be transparent and real about the fact that yes, some people have side effects. And we can absolutely be very reasonable to frame that as, this is the vaccine working. This is how you know you got something in your arm, is, you may feel a little bit of this stuff. It's not making you ill, and it is a sign that the vaccine is working. And this is going to be a very unprecedented, very, very public rollout of this vaccine. So we have absolutely unprecedented public attention and scrutiny on this vaccine, in addition to the very formal additional layers of protection in place. So we've had, of course, for many years, generations of the VAERS system and the vaccine safety data link, et cetera. But now, of course, we have vSafe. So you can just show people the app and say, hey, sign up for the app, put the information yourself. You can directly see that your experience is going into this database, and that we are literally getting millions of data points per week on how people are doing with their vaccine. And again, if you as a healthcare provider did do that app, I certainly did, it still sends me the text, then share that with them and say, yes, I'm directly telling the CDC what my personal experience is with this vaccine, and we're doing that millions of times over. So this will have incredible, post follow-up, research. And frankly, again, just pivoting right back to the trials, in terms of the speed of the trials, the monitoring period, the reality is that when we have seen very, very rare but serious side effects from vaccines, those are fairly immediate things. So we've not really had experience with reactions that are long-term, that aren't more immediately apparent, usually within more like hours to days. And so having a 2-month post inoculation study period and observation period as our main key data point that got the authorization in place is really actually very, very reasonable. That anything that we would expect to see, we really should have seen it by then. We can always conjecture about, well, the what ifs, you can't tell me what's going to happen in 5 years. And of course, that's an absolutely scientifically valid statement. On the other hand, you also can't tell me what's going to happen to people that have had COVID in 5 years. And if we, use the information that we have at our grasp at the moment, we would certainly have more concern over what might happen to folks with the long haulers and the lingering concerns over COVID disease, far more reason to think that that might be a concern than any long-term side effects of the vaccination itself. Next slide, please. All right, so again, we do need to be humble though. So we have to be very, very careful not to lose trust. So we have to be clear and confident about what we know and why we feel this is a very, very wise decision. And at the same time, we can also be perfectly transparent about what we don't know. And primarily, of course, that's going to be in terms of overall how efficacious this vaccine is going to be, particularly with potential variants coming into play, or how long it may be and what the situation will be with boosters. So we have to be careful not to overplay that hand and be transparent about what we don't know. Next slide, please. So, again, I kind of addressed this a moment ago, jumped the gun a little bit, but again, I would worry more about the disease having lingering complications. And at the end of the day, we looked at that graph earlier in today's seminar, where we have far more people vaccinated than have had the disease, right? And we know how many people the disease has killed. So the risk benefit is just so absolutely clearly in favor of this. When we look at over 1 in 1,000 Americans already having died from this disease, the risk benefit is just so clearly in favor. So yes, again, we're being transparent. We cannot say there is no risk to this vaccine. We can say that all evidence we have so far points to it is a far, far, far safer choice over getting the disease. Next slide, please. So just quickly, normally I have at least an hour to teach this stuff, so I'm going to give you a little preview, and maybe we'll have an opportunity to talk in the future in more detail about this, but just a quick general overview of communication technique tips. So if you're anything like me, if you're human, you tend to fall into a little bit of lecture mode, a little bit of kind of judgment, a little blame and shame. We tend to correct people's mistaken ideas. And what we've really, really learned in this area is that really doesn't help, and that oftentimes it actually makes people a little more stubborn, a little more reluctant to get the vaccine. Next slide, please. So we want to be careful not to just kind of, throw facts at people and kind of feel like we're having a debate. So getting out of debate mode is key. So we go to persuasion mode. So your key is to help this person reach the decision to vaccinate, not to somehow win debate points. So you don't have to correct every mistaken idea. And as much as we hate to think about it as public health folks, that, really evidence is not what changes people's minds, okay? Yes, we have to still provide it. This is a new enough vaccine, a new enough situation and that those questions have to be answered, but know that we're far less rational in our decision making than we all would like to admit. And so simply providing evidence is oftentimes not enough to change people's minds. That's a big, big take home today. Next slide. So, part of our other nuanced approach is realizing that, yes, we can say that us and the CDC or whoever have these opinions, but folks' opinions is very much driven by groupthink. And that's oftentimes whatever their group identity is. That could be their family, friends, church, neighborhood. Oftentimes, of course, it's their social media groups. And lots of important work, if you didn't see that this week, by Facebook, so kudos there. But, we're still going to have social media as a presence in terms of people having their groupthink reinforce their beliefs. And so when we attack people's own identity and beliefs, we're bound to fail. And when we attack people's group identity and beliefs, we're also bound to fail. So we're looking for places to align with people, align with their identity, and align with their group as much as we possibly can, rather than malign it. So next slide, please. So yes, again, we're not debating. We can, just take a deep breath, realize this is all very new with so much misinformation and politicization of the facts at hand. We really have to understand that people, again, do need some basic questions answered, as I've done for you today, and be transparent about the limits of our knowledge. Next slide. So tone setting. So again, this is not a debate. This is not the hard sell. We make it easy to agree. When people feel like they're being challenged, when people feel like this is going to be a difficult, stressful decision, they get backed into the corner, and we know that that decreases their intent to vaccinate, right? So they're going to kind of get a little frightened. They're going to double down. They're going to defend their beliefs. They're going to bring to mind all these reasons why they think this vaccine is not a good idea for them, and that tends to just reinforce their own position. So again, please don't debate, folks. Next slide. So yes, we always just want to win with clear, confident recommendations. So we want to be very, very clear. We're not just asking, hey, had you thought about the COVID vaccine? We want to be able to quickly reassure and give a confident recommendation. We've seen lots of data on this with things like flu vaccine, HPV vaccine, et cetera. So we have lots of great data already that a statement works much better than a question. So I see you haven't gotten your COVID vaccine yet. I'd like to take care of that today. Do you have any questions about that? So this lets folks know that this is absolutely our standard of care. It's absolutely what we think is needed and required to protect them the best. And we're going to be absolutely unapologetically clear about that. Next slide. Again, we talked a little bit about identity. So anytime we can just, again, pull into people's identity that, yes, we acknowledge good intentions and avoid judgment wherever possible. That, yes, great, I'm a pediatrician, so good, of course, as a parent, you want to make absolutely sure you've done your due diligence to make sure that Sarah is healthy and protected. I'm glad you're asking this question. So we play into that good identity role. Next slide. The other thing that we can do, again, is emphasize our common interest, and that all goes back to the why. So there can be suspicions, of course. Well, is this just, are you just making money off of this? Is this somehow big pharma or some other pressure that's coming to bear, and that's why you're recommending this for my family? And so coming back to just simple phrases of, hey, we're in this together. What we both want is for Sarah to be protected. I think this vaccine provides important protection for you. Or, hey, in this exam room, it's just us. It's about you and me and finding out the best way to protect Sarah, and this is how I think we should do it. Next slide. And then lastly, almost last, how do we frame the conversation? And this is a little bit like politics, but there's a reason that politicians tend to stick to their talking points, stick to the why, try not to get dragged down in the weeds too much, and that works for us as well. So again, yes, we answer questions in a short soundbite as much as we can, and then try to pull back people into the why. If you end up going back and forth too many times, arguing over some nuanced theory about why the vaccine could potentially be harmful, usually you should just kind of wake up and realize, okay, this is probably going to go downhill quickly. As soon as I can get back to why this is important, why this disease needs to be stopped, that's the best. And then ultimately, again, it leaves people with a sense of a reminder that this is why I think this is important. And this is, yes, why I'm going to keep bringing it up every time I see you, because it's just that important to me. And so, we play the long game. We're not going to convince everyone the first time. We have to foster our trust and respect for each other and play the long game there. Next slide. I'll briefly mention that anything that we can do to help make this messaging through every touch point through the healthcare system would be very valuable. And I'm probably out of time here, so next slide. All right, so there we go. Last slide. So bottom line, my little thing is, the American dying about every 30 seconds from this disease, we really want to do everything we can to protect folks. So thank you.
Thank you so much, Ken. Such wise words in this important thing. Next up is Dr. Hendry Tan. Dr. Tan is the Associate Vice Chancellor for Health Equity, Diversity and Inclusion, and a clinical professor of psychiatry and behavioral sciences at the University of California at Davis. He serves as the Director of Education at UC Davis for reducing health disparities. He's also the founding medical director of the Transcultural Wellness Center of the Asian Pacific Community Counseling. I hope I got that right, Dr. Tan. He does regularly receive teaching, leadership, and community awards for his work with healthcare professionals and underserved communities. And again, I could say so much more, but let's hear from him. Thank you so much for being here.
Thank you, Dr. Newell Green. I just want to first say how thankful I am of Dr. Hempstead. He gave an incredibly practical, wonderful presentation on addressing vaccine hesitancy at the bedside. I'm going to address vaccine hesitancy in communities of colors. Next slide. So if we can get the next slide, please. Yes, thank you. So if you look at the California data, and this is updated in early February, so just a couple of days ago, you find that the impact of COVID-19 has been disparate amongst various communities of color. So if you look at the Latino community, they comprise of about 39% of California's population, but 46% of the deaths. If you look at Asian Americans, the death rates are low, but if you look at the case fatality rate, it suggests that when someone gets COVID-19 who's Asian American, their chance of progressing on to death is higher than other populations. So there's something going on about not just about the infection, but how the infection progresses in Asian Americans. We've had a lot of concerns nationally about African Americans and the Black community's rate of infection and death as a result of COVID-19. In California, we're seeing that these numbers are better than they used to be, with Black communities representing about 6% of Californians and 6.4% of fatalities. Also of concern are Native Hawaiians and Pacific Islanders. They make up 0.3%, but 0.6% of the deaths from COVID-19. So we're seeing a disproportionate impact. A lot of people, talk about the significant health disparities and how they're magnified by COVID-19, and we are seeing this across the country. But I also want to highlight that we are also seeing an unprecedented systematic effort to address these health disparities, both at the level of the national level, as well as at the level of California and the local jurisdictions as well. I have not seen in the past such an incredible coordinated effort to address health disparities in structural ways, and that gives me a lot of hope that we can address these significant disparities in due time. Next slide. So if you look at the willingness to get a COVID vaccine, you'll notice, as the other speakers said, that is improving. So even amongst Black, Hispanic participants in this survey, which was done by the Kaiser Family Foundation, you see that the willingness to take the vaccine has increased by about 12% in Black communities, about 11% in Hispanic communities, which kind of parallels the white community population of about 8% increase. So things are looking better. Next slide. Having said that, as Dr. Hempstead talked about, there is still quite a bit of concern about the COVID-19 vaccine. And what I want to highlight in this chart is that the concerns that we see in Black and Hispanic people are significantly higher percentage-wise than in white or general population. So the long-term effects of COVID-19, which Dr. Hempstead addressed, the side effects, the question of whether or not it's safe, the question of whether or not it's effective, and even if you look at this, the concern that you might get COVID-19 from the vaccine. Only 20% in white communities, but the majority, 50% to 54% in communities of color. So this really speaks to the challenge that we have as a health and public health community to effectively communicate and educate the public about these concerns. Somehow we are having better reach for general population, for white populations, than we are for Latino and Black communities. Next slide. And of note, this is reflected in Black and Hispanic people's perceptions of the accessibility of information. So there's a disproportionate number of people from communities of color who are saying that I don't have enough information to really understand the side effects and the effectiveness of COVID-19 vaccines. So again, we're having this communication gap, but not at the bedside necessarily, but in the population at large. Next slide. And as a result, the confidence in the vaccine is significantly impacted. So you see here in Black community members, about 50% still have concerns. And the concern in this case is specifically, was the development of the vaccine taking into consideration the needs of Black people? And similarly with Hispanic adults, about 40% of people are concerned that the vaccine production and development took into account the specific needs of Latino and Hispanic people. This is resonant of a lot of narratives that Black and communities of color have had about the public health and other research endeavors, that research is tailored towards the dominant white population, and that there's limited consideration given to people of color. And so given that, why should we trust that the vaccines are safe for the people that we identify with? That's a major concern. Next slide. But the good news is that Pfizer and the Moderna vaccines did take into account communities of color. So if you look at the participants in the trials, you see that for example, for Hispanic people, 17% of the population, 20 to 26% of the participants. So Hispanic people were oversampled, overrepresented in the vaccines. And if you look at Black communities, not quite as high, 12% in the general population, but about 10% in the Moderna and Pfizer vaccine. So there was attention paid to making sure that the vaccines are safe and account for the experiences of communities of color. But not very many people in communities of color have heard about this. And so this is one additional thing that's, in addition to what Dr. Hempstead said, one additional factor that you can point out when addressing concerns about whether or not the vaccine took into consideration people of color. Next slide. So I want to get to the message given the data that we've covered. Next slide. So Dr. Hempstead went over this in much more detail than what I will do. I'll just overview some critical areas here. This was a study done by the Ad Council COVID Collaborative. They're a large national organization that really looks at persuasive communication. So as Dr. Hempstead said, it's important to validate concerns, acknowledge people's hesitancy rather than changing it. As he said, you can't trump beliefs, but you can acknowledge those beliefs and find ways to align. You can focus on moments missed, so things that you missed because of COVID-19, to help to address the COVID-19 fatigue. So things like, you might have missed, being able to hang out with family and friends during Thanksgiving. Oh gosh, wouldn't it be nice if we could do that? Well, this offers a pathway for us doing that, this vaccine. Emphasize protection rather, and specifically for communities of color where there's a strong sense of community collectivism. emphasizing that this is what I'm doing as a provider to protect myself and my loved ones, and to protect my community. We've shared messages from physicians of color who say that this is one of the ways in which I'm addressing the health inequities found in my community by getting the vaccine, and I want to urge you to do the same thing. So this theme of protection is really mobilizes people's altruism, and for communities of color, people's sense of community and cultural identity. And of course, having a positive tone, as Dr. Hempstead said, this is not a battle where shame comes into it. It's more about being inviting and respectful. This is particularly important for communities of color who typically, oftentimes when they go to see their providers, there's a feeling of oftentimes of shame in not being able to pursue the recommendations of their provider. So they come in maybe feeling a little hesitant to describe what's been going on in their family. And adherence to treatment oftentimes has to do with communication barriers, access to the resources to implement those recommendations. And so by having an inviting and respectful tone, you're welcoming people and you're providing that inclusive environment, whereas confronting really exacerbates and perpetuates this sense of not being included in the health system that many people in communities of color struggle with. Next slide. So elements that don't resonate, I'm not going to go into too much detail, as Dr. Hempstead covered it in so much better detail. Avoid negativity, avoid guilt, avoid over-promising, and avoid this idea of if we get this vaccine in people's arms, we'll get back to normal. This is especially important for people who are in communities of color, where the impact has had a very strong and long-lasting negative effect in communities where people have lost loved ones disproportionately. Essential workers have been exposed. People in the Asian community, for example, the rate of unemployment claims are disproportionately high in Asian American communities because of COVID-19. And so the message of let's get back to normal can seem tone deaf to people who have had significant and long-lasting negative experiences with COVID-19. So focusing on, again, on missed experiences may be a better way than this idea of being back to normal. Next slide. So some do's and don'ts. I'm not going to go into too much detail, but talk about vaccination instead of injections or shots, safe and effective instead of focusing on the quick development of it, focusing on family and those that you love rather than on the country, given the divisiveness. Focus on the messages from health and medical experts rather than on scientists. And this is particularly, again, relevant for communities of color where, especially, for example, in Black communities where scientists did actually contribute to significant harm. And you can think about the Tuskegee experiment as an example of science doing harm to a community of color. Next slide. So some of the messages, what I've found to be very important to do is to acknowledge that there is legitimate distrust in government and that there is historical racism that contribute to a legitimate concern about the messaging of the government around COVID-19. I found that when I've expressed that, and I'll say things like, I want to spend a moment to talk about the COVID-19 vaccine. I've heard a lot of concerns about the vaccine and distrust in the government and the messages sent about the vaccine. And, given the historical racism that many people in communities of color have experienced, I get that distrust. And I want to check in with you and see how you're doing with that. That gives your patient the opportunity to accept your invitation to talk about the mistrust. And it gives you the opportunity to acknowledge that and to become a trusted messenger, because they understand that, hey, you know about these. So when you're advising them about the vaccine, it's in the context of understanding that there has been racism, that they don't have to convince you either overtly or secretly that there are these concerns. It's out there in the open, you're acknowledging it, and that's really important. I've found that when I've had these conversations, the dialogue around vaccine hesitancy and the concerns about that are much more honest, and we can have a candid conversation. Address concerns about equity in the vaccine development. There has been a lot of attention to equity, and this has been a strong narrative in communities of color around the exclusion, the traditional exclusion of Black and Brown people in treatment development. As I said before, address concerns about side effect and focus on how vaccines can help families and communities. This has been shown in a number of focus groups that actually the state public health department has done, showing that messaging around protecting family is especially resonant with Black and Hispanic families. Next slide. So let's talk about the messenger and medium real quick. Next slide. So this slide suggests that doctors are a high credible source. So we as physicians are credible sources of information. Next slide. Doctors, health professional, public health experts, promotores, health navigators, trusted community members, community health workers, cultural centers, family members, community activists. These groups are very important in several ways. So one, we as doctors can serve as trusted messengers, but we also need to have a way to get our message out. That's the medium part, okay? Given that a lot of people don't have good access to us as healthcare professionals in our clinic, we need to find a way to get the message into the community beyond our clinic doors. These are where promotores, community health workers, community activists, and community centers can help us to have that pipeline, if you will, that communication network to communicate our message as trusted messengers. And it can be very helpful to have race ethnic concordance, so that if there's a provider who shares a cultural background with the community members, that can be very helpful in building that trust and credibility. Next slide. The medium, so it's important to disseminate information in language and in culture. You know, there's a lot of work that's being done online to connect people to vaccine clinics. The challenge about this is that people have to be computer literate, and people have to know either Spanish, written Spanish, or written English, which is a challenge for a number of communities that we have in California. So addressing gaps in communication flows. This also includes farm workers who are out in the fields and often don't have access to the technology that it takes to get them the information. And as our prior speaker said, testimonials from real people serve as a powerful medium of communication. Next slide. Finally, I want to shift beyond just communication directly about vaccine hesitancy to also talk about infrastructure for that communication and engagement. So I want to make a distinction between hard to vaccinate populations where there's high vaccine hesitancy and hard to reach populations where there may be actually high vaccine curiosity and engagement, but they have a harder time accessing the health system. And there's a quote that was that I want to share from a recent JAMA article. In most cases thus far, the process of making an appointment to be vaccinated requires substantial time, technology, and trust. 3 resources that are unequally distributed in much of the US population: a rapid digital connection, time to repeatedly refresh the links, The ability to travel to the vaccination sites, trust and safety in the vaccine are factors that, feed into this. Just in the last minute, I want to share with you a resource. Next slide. So if you skip the slide. If you look at the California Healthy Places Index, this is a great resource for you to look at your local communities. For example, I look at a community in South Sacramento. I see that the Healthy Places Index score is 6.9, meaning that the social determinants that contribute to health, this community is in less than the 10th percentile. Next slide. If you delve into some of the parameters, you can see that there are various factors that are really critical for accessing the vaccine, such as, next slide, transportation. So in this community, the transportation, residents are in the 5th percentile in terms of vaccination, in terms of transportation. And so when thinking about the structural issues that impact hard to reach communities, we want to make sure that we have mobile clinics in this area. A centralized place for vaccine distribution may not work for a population in which 5%, 10% have access to automobile transportation. So in addition to thinking about the bedside, we want to think about the structural issues that contribute to the disparities around vaccination. Thank you so much.
Thank you so much, Dr. Tan. As usual, I want to spend more time with each of you, and I know that our audience members will too. I do want to leave the last few minutes to invite in our final presenter and our old friend, not old in the way that I'm old, but Dr. Eric Capon, who is our California State Epidemiologist and the Deputy Director at the California Department of Public Health. So dive in, Erica, and tell us what's going on in the state.
Great, thank you. I'll try to kind of fly through some of this. There's a little time for questions, but always nice to be here. And actually, I love the tee up on the HPI because I'll talk about the Healthy Places Index and how we're thinking about using it for vaccine. So yeah, I'll just give you a quick update on how things are looking as far as epi in California. A little bit about variants. I know that's a hot topic. I can tell you kind of what we're seeing and planning as far as whole genome sequencing, and a little bit about our Vaccinate All 58 campaign, which I think again was touched upon, which is great. Although I'll acknowledge I didn't catch the wonderful speakers beforehand, except the end of Dr. Tan. So hopefully I won't have any too much duplication. Next slide, please. So, just, this is from our dashboard that you can check online. We have over 3.3 million cases in California, 44,000 deaths, sadly, and we're still seeing, actually the numbers overall and the peak of that has passed, but we are continuing to see deaths. And then still lots of testing, although some overall gradual declines, although today back to 329,000, we've ranged anywhere from like in the 150,000 a day to 330,000 a day. So there's been some more fluctuation lately, which we've been watching closely to make sure we're not just testing less as far as detecting less cases, but we're also seeing a decrease in test positivity as well. So that's encouraging. Even when we've had low volume of testing, we're still seeing low test positivity as well, which are all promising trends. Next slide. So this is what we call our epidemic curve, and I'm excited to share that very soon our actual dashboard will have a version of this that you'll see. What you see now on our dashboard is really when we get the report date, but this actually looks at when people were tested or when they first reported symptoms, and you can see our peak in July, which seemed huge at the time, and our surge, and then our huge winter surge, but you can see we're well beyond the peak of that. The highest date was on January 4th. We had, I think, almost 60,000 cases that day, but we do see a continuing decline. So we're very, encouraged to see this continuing decline. Next slide. And then this is just a nice way of looking at a different way. The blue line is the overall cases in that peak. The little chunk in the middle there is when you saw a lot less testing during the holidays and over Christmas. And then the orange line is that you can see our hospitalizations are definitely on the down, the decrease as well. And the black line on the bottom is our intensive care unit. So again, all trends looking very promising. And these really are happening statewide, which is encouraging. And then the red line is the deaths again, and seeing that the other point here is that typically our peak in cases is first, and then you see the peak in hospitalizations and deaths a little bit later. Next slide. And then this we just have been showing, some of you may have seen this on one of the prior press conferences with either Dr. Galley or the governor. But we do, when we look at modeling and try to look at what happened when we did the regional stay-at-home, we do have evidence that probably 25,000 fewer people were hospitalized with the regional stay-at-home, and then about 5,000 we estimate fewer were in the intensive care unit based on the regional stay-at-home, which was implemented right around the beginning of where this graphic shows. And if we'd stayed on that same trajectory, this is the difference, whereas we did flatten that curve. So again, thank you to all Californians and everything that you all did as clinicians to help make sure we were doing our best as a state to stay at home and avoid all the interactions that lead to more transmission. Next slide. So variants, again, I know this is really a hot topic right now. So we have sequenced over 12,000 isolates in the state of California, and actually that's a huge proportion of nationally. While we are nowhere near the UK and I forget the other country that does a lot more, and that's certainly a goal. We do a lot more sequencing here in California than in most other states. These sequences that are done through a whole network of labs, in California we call it COVIDNet. There's a lot of both public health labs and private labs and academic labs. They all typically sequence and upload this to an international database called the GISAID. I'm blanking on the acronym right now. But so one interesting issue with that is that all of those sequences are uploaded, they're all de-identified. So we download that data and can see again how many sequences are done. It's been between like 1,000 and 1,500 a month for the last few months, and we can see what proportion of variants we're seeing, but we have to do a lot more work to actually find and match it with cases and investigations. So thankfully, a lot of our California labs have close relationships with local health departments and are notifying local health departments, or we help do that matching. But that is an area that we're really working now on ramping up how those data systems can better integrate so we can continue to do more aggressive epi investigation of all of these variants. So you've been hearing about nomenclature is also an issue. There's no international standard for what to call these things. So that's why you might see different names and nomenclature in the media and other academic reports as well. The ones we've been seeing a lot of in California, but have been detected in multiple other states, are B1429 and B1427. And then of course, the one you've heard the most about is the UK or B117 variant. So we've had over 800 of the B1429 and 1427, and about 153 from the UK variants in California to date. Still, thankfully, no evidence of the South African variant or the Brazilian P1 variant. There was a P2 found in Northern California that does not have the same concerning mutations. And the next slide will explain a little bit more about these. Next slide. So again, the B117 has been found first described in the UK and in at least 46 other countries. We first saw it in the US at the end of December, and CDC is continuing to track and update number of cases in the US. We are starting to report that publicly as well as we're tracking in California. We've been seeing it in multiple different jurisdictions, both Southern and Northern California. And then the South Africa one, again, this is the one that's been the most concerning as far as vaccine efficacy issues. So again, that's first found in South Africa. None has been detected yet here in California. And then again, these Brazilian P1, Brazil and 4 other countries, and then first detected at the end of January 2021 in the US. So again, CDC and the GISAID are tracking all of these internationally. Next slide, please. So these are the two that are sort of related in California that have been detected at UCSF and Cedars-Sinai and Stanford, again, in multiple different jurisdictions in the state. These were actually first detected in California, but just more sporadically in mid-July, and certainly in more specimens over the last few months. Again, we're sequencing more specimens too. So what we're working on as a state is having a more aggressive systematic sequencing where our goal is to get to 2% of all specimens are sequenced. Right now, it's actually less than 1%, but again, more than in most other places. So these, when we're reporting these variants, I think the mutation we talked about was L452R, which is in both of these variants. And then the other GISAID nomenclature is B1429 or B1427. And again, we've seen over 800 of these in California to date, and they are in about 10 other states. So we're still, there's a lot of active work about whether or not there's any change in response in vitro to monoclonal antibodies or polyclonal antibodies and vaccine efficacy. Those studies are underway. We don't have any evidence yet to say. CDC is actually not considering this a variant of concern, which is what they have named the other ones that I showed on the previous slide that have more concerning mutations. So because we still have less epi data, and again, therapeutic or vaccine efficacy data on these, there are still variants of interest, but not necessarily at least deemed by the CDC as of concern. They have been associated with some outbreaks in California, but also in the middle of our surge, so hard to know for sure if it's just, you know, a strain that is here, but not necessarily different than the prior wild strain. So stay tuned. We're again actively investigating this, and we'll be keeping all of you up to date on that. Next slide. And then I think, as you all know, here's the two main vaccines that are being distributed now. I'm sure you also have heard about the Janssen request for approval. So at the end of the month, there's going to be an FDA VRBPAC committee to evaluate Janssen for EUA, and then we'll immediately have our Western State Scientific Safety Work Group review that as well for consideration in California. And of course, the exciting thing about the Janssen vaccine is that it's 1 dose rather than 2 doses, which will be, you know, obviously logistically a lot easier to do. The drafting guidelines work group has done an initial recommendation about which populations we might want to strategize using this vaccine that are harder to follow up or other things, and they're finalizing those recommendations. They'll be submitting them to the state of California and our administration. So more to come on all of that. Next slide. And we do now have a vaccine dashboard that is up on our COVID-19 website. So very happy to say we're getting close to 5 million doses administered. And then not on this dashboard yet, but I know that we have delivered at least well over 800,000 second doses have been administered. So over 800 people are fully vaccinated, 800,000 people are fully vaccinated in California. We are still admittedly working on a lot of the reconciliation of doses administered by county of residence. So we have put this dashboard up, but I will say there is still a lot of ongoing work trying to reconcile. I think there's a few different data systems that all need to align, and we continue to find some gaps in that. So we actually think there are probably a lot more doses administered than are actually in all these data reports, but we're continuing to improve that data quality. And then similarly, just over 7 million have just been delivered in the state of California just as of recently. And then here's the numbers for the CDC long-term care facility partnership. And they are scheduled to finish all of their long-term care vaccinations for that phase B by, I want to say, the end of March. I think is mid-March or end of March is when they're scheduled to complete all of those vaccinations. Next slide. And then we'll kind of just quickly mention, so I think you all know phase 1A was healthcare workers, long-term care residents, skilled nursing facility. We estimate in California that's about 3 million people. And next slide. And then phase 1B tier 1 is including persons 65 years of age and older. And I know many of you have appropriately prioritized people 75 years of age and older as the highest risk and sort of the subset of this. And then certain sector populations that we have noted to be of both high risk and high exposure include agriculture and food, emergency services, and education and childcare are all part of the tier 1 that we are in now and trying to vaccinate. This group encompasses, we estimate, about 8.5 million people. So you saw that we've only received about 7 million doses, which is only covering about 3.5 million people. So we still have a long way to go to have enough vaccine to offer to everyone in this tier. After this, we are actively working on as well how to incorporate persons with high-risk medical conditions, including disabilities, into making sure that they are prioritized in some way, and also making sure as we shift to an age-based framework after this tier, how are we going to achieve equity? So We have learned a lot from feedback from all of you on the front lines about how difficult it has been to operationalize a lot of these sort of priorities and sectors. So have shifted to what will be an age-based framework after we finish out this tier, but we are going to be working very aggressively on how we do engagement that prioritizes the disproportionately impacted communities and settings and populations, and ensuring those who are eligible for vaccines within these communities are most likely to receive it. Next slide. So this is just some links, some other resources for providers if you're having questions about vaccine administration and the call center for provider numbers. Next slide. And then just to try to quickly run through our campaign overview, kind of a nice follow-up, I think, on some of the talks you had earlier today. So we have Vaccinate All 58 as our big campaign, and we are working again to really improve our messaging to disproportionately impacted Californians, so providing key facts, addressing barriers like lack of access and hesitancy, and then helping navigate the vaccination eligibility process. So there's some downloadable materials at this website here, the Toolkit COVID-19. Next slide. And again, really informing our campaign decisions through a data-driven approach, really looking at the Healthy Places Index that Dr. Tan just mentioned, looking at our COVID-19 positivity rates, where doing sort of social media monitoring to see what kind of misinformation and disinformation are out there, and qualitative and quantitative research as well. Working on communication efforts with cultural humility, making sure we're doing our best to work with making sure there's in-language communications, addressing hesitancy again, focusing on our ethnic media. We've done some really targeted outreach sessions for different components of ethnic media. And then really importantly, as was just mentioned, working through trusted messengers. So deploying campaign messages by leveraging trusted messengers with existing networks to engage hard to reach populations. Next slide. So we have actually also disseminated $30 million for workplace and community health outreach projects in partnership with 150 CBOs. Over 17 million has been awarded to date, and more expected by the end of the month. And our network is working in partnership with the Sierra Health Foundation and the California Community Foundation. So really prioritizing, again, high quality engagements related to COVID-19 vaccines, and also with harm reduction, workers' rights, and providing referrals to safety net services. And we'll continue to engage efforts like this to deploy in coordination with philanthropy, other local health jurisdiction efforts, and other state agencies and partnerships. Next slide. And I'll say, I didn't actually touch on, I didn't have a slide. We are, in transition to move to this third-party administrator, which will be centrally providing all of the allocations for all the providers, and working on a way to really, to my other point about making sure how many doses have been administered, having accountability around that and improve all the data tracking. With that third-party administrator, we are absolutely working on allocation formulas that will be disproportionately, again, providing vaccines to the lowest HPIs, and also how we're going to track that over time. So we hope to launch our dashboard showing our vaccination rates by race and ethnicity very soon, within the next week or so. And again, we'll be, oh, thank you. One of my backup slides is here about the third-party administrator. But anyway, working closely on how that allocation formula will work, and also with pay for service engagement for working with CBOs for vaccine administration, making sure that the providers get additional funding to do translation services, mobile services, again, reaching our hard to reach population. So we'll be working with the TPA to make sure that we don't, we are, again, trying to balance getting everyone vaccinated as quickly as possible, but also maintaining our equity approach. So with that, knowing it's short on time, I will stop and see if we have just a couple minutes for questions.
Thank you so much, Erica. And I just want to thank everyone. Today we've had a really robust group of speakers talking about vital issues, and we do not have time for questions today. But I want to just preview our next COVID-19 virtual grand rounds, which will be taking place on Tuesday, March 9th from 12 to 1:30. We'll hopefully have Dr. Pan back, but that's really going to focus on many of the questions that you all had today, which is really detailed conversation with an expert on vaccines about the new vaccines, about what information and data is coming out of the vaccine studies that we're seeing now about efficacy and about all kinds of issues. And we're also going to have someone back to talk talk more in detail about our variants. So hold your questions until then, but don't hold your breath. And I really do want to call out that, as I said earlier, Erica missed it, but we have crossed the point where in California is where in the nation we have vaccinated more people than have had COVID-19. And so I just want to say virtual fireworks and real congratulations to all the people who are in the field. You can just hear Erica racing through these slides, but the amount of work that goes through what's happening in our state is enormous, and really grateful. I'd love to see your faces if you want to pop on quickly to Dr. Tan and Dr. Hempstead and Dr. Shuker, who isn't with us anymore. Thank you all for being here, and thank you to our audience for coming. Please do share this on, it will be up on our website, covidroundca.com, to be able to distribute with the slides by this evening. So thank you all, and have a wonderful spring in California.
Thank you.
Thank you so much.
Thank you.